Navigating the perplexing waters of andropause. Actually, it's not that perplexing. Low testosterone is very dangerous. Hi, I'm Dr. Robert Carlson. I'm a board-certified general surgeon, board-certified cardiothoracic surgeon, practicing heart surgery for about 15 years, and I've been involved with age management medicine for about the last 10 years. To my right is my heart, and despite having a significant family history of sudden cardiac death and heart disease at the age of 57, I have no calcifications or any coronary artery disease. I feel that the importance of balancing hormones has been beneficial in my circumstances, and will show you how I think it could be beneficial in your circumstances. First, I want to talk about low bioavailable testosterone. And we'll go through that a little bit more. But in fact, this low bioavailable testosterone is a lethal, systemic, inflammatory disease. This is not healthy at all. It's related to sarcopenia, or loss of muscle mass, memory loss, loss of energy and motivation. This increased inflammatory state, increased heart disease, increased prostate cancer, and sexual decline, all related to low testosterone. This is a video of me doing off-pump bypass surgery, and what I like to do is try to avoid anybody having to have this done. Here is the internal mammary artery. Here is one of the vein grafts. The key here is, how can we optimize someone's balance, optimize their hormones, and reduce their risks of ever having to have a procedure like this performed. In Circulation in 2007, which is an article, it's the Journal for the American Heart Association, in 2007 showed how testosterone was really truly related to all these cardiometabolic processes. For instance, in male hypotestosteronism, or low testosterone, we see a higher incidence of hyperglycemia, higher incidence of these cytokines that make diabetes worse and really dramatically affect the health and inflammation within the system. Certainly we see metabolic syndrome, which is a combination of dyslipidemias, increased abdominal fat, hypertension, and high sugar. These four together are strongly associated with heart disease, and managing them with testosterone therapy will dramatically reduce the incidence and the development of metabolic syndrome. Certainly we've seen atherosclerosis related to low testosterone, insulin resistance having to do a lot with this visceral abdominal fat that creates these cytokines that blocks the ability of sugar to enter into the muscles. And ultimately, these high insulin levels cause increased abdominal fat, which this vicious cycle proceeds forward. Low testosterone is also about loss of vascular tone and increased vascular stiffness, and this dyslipidemia that we see also with this metabolic syndrome. Previously, it's been reported that men with low testosterone levels actually had an increased mortality, with about a doubling in the mortality risk compared with men with normal testosterone. What? Really? Low testosterone caused higher incidence of mortality? This study here in the Journal of Clinical Endocrinology and Metabolism 2012 showed that testosterone treatment in middle-aged and elderly men who greater than 40 years of age, with starting low testosterones of less than 250, were associated with a reduction in mortality from 21% down to 10%, just with management of testosterone. Testosterone has been shown to reduce fasting glucose levels, reduce waist circumference, improve the surrogate markers of atherosclerosis, like the elevation of C-reactive proteins, the elevation of interleukins, IL-1, 2, all these inflammatory markers are seen in hypergonadal men with metabolic syndrome. And resumption and maintenance of testosterone levels into a normal range of young adults. Note, not a normal range of a 75-year-old. A normal range of a young adult will determine a remarkable reduction in cardiovascular risk factors clustered in the metabolic syndrome without significant hematologic or prostate adverse effects. This is a study out of the Journal of Sexual Medicine and was published in 2010. I want to talk a little bit about this busy looking slide. It's called the stereogenetic pathway. Now, one of the things in regards to cholesterol, I always say that testosterone is very significantly affects cholesterol levels. And let me show you this here. First of all, what's the difference between a 20-year-old who is eating Taco Bell, Kentucky Fried Chicken, and rinsing it down with a strawberry milkshake from McDonald's, and has a normal cholesterol, and a 48-year-old who's eating lettuce with a raspberry vinaigrette and carrots, and has a high cholesterol and is being threatened with a statin? And the answer is testosterone. That's the difference. So let's talk about this here. How does your body build testosterone? Well, first of all, when testosterone's low, the body will produce an increased luteinizing hormone, which tells it to make more fat in the belly, particularly visceral fat, all these additional collections of fat in hips and thighs, and even in breast tissue in men with high estrogen levels. Now, what happens is when the body is getting this signal to make more testosterone, actually, if you follow the step, this is the process of creating testosterone. So let's follow it one step at a time. Oh, wait a second. The main building block for testosterone is cholesterol. So if the issue here is that your body senses a lack of testosterone, and the way it corrects for that is to increase absorption of cholesterol and process more LDL cholesterol through the liver. And in our infinite wisdom in the medical society, we block this effect. So guess what? Testosterone levels will stay low and these risks increase. We need to allow cholesterol, which is very valuable in the brain. It's very valuable in digestion, bile enzymes. It's very important in bile acid production. Also, as you can see, here's cortisol. So you need to make cortisol, you need cholesterol. So this is a very important pathway, and the key here is cholesterol is not our enemy. Inflammation is. And low testosterone, once corrected, will reduce this total cholesterol and LDL cholesterol levels. This particular article talks about the association of testosterone therapy with mortality, myocardial infarction, and stroke in men with low testosterone. This disgusting, horribly performed, terribly researched article was published in Journal of American Medical Association recently, 2013, and has actually created a tremendous amount of attorneys appearing on TV asking if you're on testosterone therapy and had a heart attack, do you want to sue? The problem is this study has nothing to do with most people taking testosterone. In fact, let me outline how horrible this study was. First of all, this study is only an average age of over 60, and these men, to enter into this study, number one, had to get a cardiac cath at the VA. So they have known coronary disease. In fact, 80% of them had known coronary disease, and over 40% had already had a heart attack, and over 50% have diabetes. And of course, in this VA population, I wouldn't be surprised, a significant number of them smoke as well. So what they did is they took the group that had a normal testosterone and didn't treat them, and the group that had a low testosterone, they treated them with either injections, low-dose injections, or creams. A couple real major issues here. First of all, 20% of the men who started the therapy in this 3-year trial stopped in 1 month. So they're not even, and they aren't included in the testosterone therapy group. Number two, 60% of these individuals actually had their blood levels checked. And of those 60%, the average was an increase from 170 to a number of 325. Well, as far as I'm concerned, 325 is still significantly undertreated and would constitute a reason to treat someone, not as an acceptable point to have treated and a goal to obtain. And in fact, there's been studies that have shown clearly that individuals with testosterone over 550 had significant reduction in mortality compared to people who had testosterone in the 320s. So, again, horrible study. Now, other problems with this study, again, over half were diabetic, so a lot had this high visceral fat. No estrogen levels were obtained, and no attempt at trying to control estrogen was performed, which I think is really outrageous, that they could manage testosterone therapy and not try to control estrogen, because as far as I'm concerned, estrogen is strongly associated with heart disease and prostate cancer and needs to be managed or at least attended to. Otherwise, there'll be significant complications. So this study shouldn't say testosterone therapy with mortality and myocardial infarction and stroke in men with low testosterone. It should say in a high-risk cardiac group with known heart disease and heart attacks and diabetes, that under treatment with testosterone leads to a higher incidence of mortality and myocardial infarction, which has nothing to do with the majority of the men who are being treated appropriately. I really find that Journal of American Medical Association's, the journal there did a poor job on allowing this really poor article to enter into the news. I think it's very disconcerting, and now you have all these attorneys thinking they can make a lot of money out of a crappy study that has nothing to do with the population who is utilizing testosterone. So this recent negative news, very poor study. It's actually meaningless. It's only in the VA patients with known heart disease, stroke, and diabetes. Testosterone levels never reached protective levels, never checked estradiol, which is strongly associated with heart disease. And as far as I'm concerned, garbage in, garbage out. The Journal of American Medical Association should be ashamed to publish this trash. More powerful review was in the American Heart Association journal called Circulation, which identified major health benefits of testosterone. The evidence does not support regarding cardiovascular risk and prostate cancer risk with testosterone therapy. This study here in urology showed that looking at men with testosterone deficiency had no increased cardiovascular risk and no increased prostate cancer risks. So we always hear people talk about that. This is a very well-designed study in December of 2013, essentially a few months before that article. Now, also, this study here in 2011 out of the Journal of American College of Cardiology, again, these are really excellent peer-reviewed journals, showed that high serum testosterone, greater than 515 nanograms per deciliter, predicted a reduced 5-year risk of cardiovascular events in elderly men 69 to 81. Now, here again is one of those problems about the high estradiol levels, and we've seen it associated with increased mortality in older men who in this particular study in endocrine and diabetes were referred to coronary angiography. And they found that there was a very high level of estradiol associated with all-cause and non-cardiovascular mortality in this large cohort of older men. I'd like to say in all men. I think the risks of estrogen are very high, including increased blood clots, increased heart disease, increased prostate size, increased PSA, increased prostate cancer, increased erectile dysfunction, increased man boobs, increased belly fat, and increased night sweats. We have to control estrogen. I prefer using an astrosol. So if you're using testosterone therapy, you have to use something to control estrogen levels or you will fail. The individuals will gain a lot of fluid. When they're walking around with estrogen levels of 150, they are much higher risk for a number of issues. And unfortunately, in medicine today, a lot of doctors are giving individuals hormone therapy with testosterone and never even checking estrogen levels, much less making an attempt to control the elevation of those. One other study here talked about how estradiol, but not testosterone, is related to coronary artery disease in men. So this is a 2011 study. Again, estrogen is associated with heart disease, not testosterone. A couple of the lab assessments I like to use for these hypogonadal males is, number one, the total testosterone. I really don't look at the free testosterone, and I'll explain why. I also like to look at the LH, or luteinizing hormone. That gives me an idea, is the pituitary not happy with the testosterone level? If so, it's elevated. And even anything over 2 or 3 is high to me. Or is there an issue with both the pituitary, which would be a secondary hypogonadism? The pituitary isn't responding, and neither are the testicles. So that indication, that would be a low testosterone and a very low LH. Now, on therapy, I often see LHs down to 0.1, and that's fine because you are monitoring the total testosterone, not the luteinizing hormone. That would suggest if an elevated LH that you were not giving proper therapy. So total testosterone levels, and I also will go through this, but to look at bioavailable testosterones between 400 and 900 is a goal. I'm happy to see total testosterones in 1,000 to 1,200. One of the big things that I see a lot and I check for in every male patient is sex hormone binding globulin. Now what happens is, as we age, sex hormone binding globulins increase. As we age, more testosterone is converted with aromatase to estrogen. As we age, the testosterone receptors are less likely to receive the proper information. So in all due respect, I think men over 50 should actually have higher testosterone levels than a 20-year-old, because all of these factors are limiting the availability of the bioavailable testosterone. Sex hormone binding globulin actually binds testosterone and never allows it to work again. I always kind of refer to it as the Hotel California, like the Eagles song, of globulins. You can check out, but you can never leave. The testosterone, once bound to this binding globulin, even though it counts as the total, is in fact never going to be functional. Now I'll show you in the next page how to calculate the bioavailable, and that's really the component of free testosterone plus bioavailable means the part of testosterone that's attached to albumin. And albumin is like a transport protein. It actually carries the albumin, carries the testosterone to where it needs to go. For instance, the kneecap says, hey, I need a 6-pack of testosterone. The testicles throw a 6-pack on the albumin. It drives to the kneecap and drops it off. So those, that free and that bioavailable are actually, and the one attached to albumin are actually bioavailable testosterone. That's what you want to see. And I'll show you in one of these individual follow-up patients how very, very high sex hormone binding globulins will actually bind all the available testosterone, leaving levels to be extremely low. So you always need to check sex hormone binding globulin. Otherwise, you're going to miss the individuals who you plan on giving them maybe 200 milligrams per cc dose, and they actually are going to need almost 400 milligrams because everything you give to them is going to be bound up in this globulin. The next question you'd say was, geez, if the sex hormone binding globulin is reducing my amount of anticipated available testosterone, how can I reduce that? And the answer is actually giving testosterone, giving maybe a little bit more than just the low levels of testosterone will actually have a negative feedback to the liver. Sex hormone binding globulin will then be reduced, and ultimately there will be, for the same amount of testosterone, you will have more free and available because less will be bound to the sex hormone binding globulin. I always check estradiol levels as well, and progesterone levels too in men. I think progesterone is a very important hormone that not only blocks stress-induced abdominal fat, helps men sleep, protects the prostate from high estrogen levels, reduces coronary artery disease, and also helps men, especially who are on the CPAP masks for snoring or for sleep apnea. It helps them take deeper breaths and keeps calm with on the CPAP mask. I always check liver functions and the PSA levels.